Greetings, masterclass and practical class members, and all members. Welcome to our Practical Pain Management with Dr. Lee, focusing today on calcific tendinosis of the rotator cuff. This discussion marks the first in our series, covering everything from the Barbotage procedure to its rationale, prognosis, and the condition's natural progression. I will discuss the technical aspect of the rotator calcification. I will discuss other subjects in the next series. Let's dive in. Overview of the calcific tendinosis. Calcific tendinosis, often called calcifying tendinitis, is characterized by the deposition of carbonate apatite crystals. Though detectable on radiographs in up to 20% of asymptomatic adults, it becomes a concern when these deposits trigger acute or chronic pain. Ultrasound, more sensitive than radiography, detects even smaller calcific particles, revealing a prevalence of as high as 29% in patients with shoulder pain. The supraspinatus tendon is particularly interesting, especially its critical zone about 1 cm proximal to its insertion. The rationale for early intervention. While conservative physical and pharmacological treatments are effective in most cases, growing extensive calcifications pose a risk of rupture-inducing chemical inflammation and tendon tear. The encapsulated calcium cavities are likely to remain asymptomatic unless they rupture. Larger calcium deposits, especially those exceeding 1 cm in diameter, are more likely to be symptomatic and have an unfavorable prognosis. Spontaneous rupture of the calcium vesicle release of calcium induces inflammation and pain and causes delamination tears. It is the first cause of pain and the major cause of acute severe pain. The second cause of pain is the delamination tear, the leading cause of chronic pain. The spontaneous rupture of calcium always leads to delaminated rotator cuff tears. The larger, the worse. Delamination tears cause relapsing prolonged pain and long-term poor prognosis, emphasizing the need for early calcium decompression. Minimally invasive treatments, such as barbotage and fenestration, are at the forefront of management to prevent a worse calcification cascade. Some calcification remains silent because of hard calcification. But the hard calcification can even cause pain if it is large enough to have mechanical properties influencing overall tendon function. The difference in the mechanical properties of hard calcium deposits and neighboring healthy tendon fibers leads to shear stress, contributing to delamination and degeneration. Neighboring chronic degenerative tendon changes might result in the development of delamination, which manifests as pain from inflamed nociceptors and step into the worse calcification cascade. I do not primarily apply platelet-rich plasma treatment in the calcific tendinosis, but situations need platelet-rich plasma treatment in this case. The single needle barbotage procedure. Now, to the heart of today's discussion, the barbotage procedure. The barbotage technique is a minimally invasive, ultrasound-guided procedure that involves the fragmentation and aspiration of calcific deposits, providing pain relief for the patient. Preparation. Needles and syringes. 26-gauge 1.5-inch for local anesthetic. 18-gauge 1.5-inch for barbotage. 24-gauge 3.5-inch needle for use as a stylet to remove the calcium plug. Several 5 ml Luer lock syringes. Drugs. 3-4 ml 1% lidocaine for irrigation in each syringe. A mixture of 3 ml lidocaine and 1 ml dexamethasone to relieve the post-procedural pain. Pre-operative ultrasound evaluation. Assessment of calcium deposits. Examine the calcification size, density, and shape. It will help in determining the severity and guide the needle approach. Designing the needle approach pathway. Identify the optimal pathway to reach the calcific deposits with minimal violation damaging surrounding structures. Procedure steps. Patient positioning. Depending on the lesion's location, place the patient in the appropriate position. External rotation for subscapular lesions, internal rotation for anterior supraspinatus lesions, and the arm sling position for posterior supraspinatus lesions. For infraspinatus lesions, an oblique supine or lateral decubitus position is recommended. Local anesthesia. Using a 26-gauge needle, administer local anesthesia starting from the skin surface and progressing to the subdeltoid bursal space. Calcific deposit localization. Use the ultrasound to align with the long axis of the calcification. It ensures precision and safety during the procedure. Needle insertion. Introduce the 18-gauge needle into the calcification center. Do not adjust or relocate the needle once it penetrates the calcium capsule, as it can cause leakage of the injected fluid. Remove the obstructive calcium or soft tissue. Occasionally, the needle may be obstructed by a calcium plug. Use a 24-gauge stylet needle to remove the plug and soften hard calcium. It facilitates the irrigation process. Calcium fragmentation. Within the vesicle, the calcium closely resembles dry, compacted sand, adhering strongly to particles and the inner walls. To facilitate irrigation of the calcium in the cavity, it's imperative to utilize the needle tip not only to break up the calcium mass but also to stir and glide within, ensuring detachment from the vesicle boundaries. Barbotage. Attach a 5 ml syringe filled with 3-4 ml of 1% lidocaine to the 18-gauge needle. Inject the lidocaine gently and slowly to mix with the calcium particles. Once mixed, the solution can be easily aspirated. Caution: the initial step of the barbotage is critical. Too much force can rupture the calcium capsule, resulting in a failed procedure. Gentle, consistent pressure ensures effective mixing and aspiration of the calcium. Decompressing the calcium can be time-consuming, even for the experts. Excessive pressure at the barbotage's onset can rupture the calcium wall, leading to fluid leakage. Consequently, the cavity won't maintain the internal pressure, making mixing the injected fluid with the calcium deposits challenging. Exercise caution and avoid applying sudden, strong pressure. It's akin to having sand in a crystal ball. Post-lavage injection. After successful aspiration, slowly withdraw the needle to the subacromial bursa and inject a mixture of 1 ml 2% lidocaine and 1 ml of dexamethasone into the subdeltoid bursal space to reduce inflammation and risk of post-procedure bursitis. Post-procedure care. Activity restriction. The patient should avoid heavy lifting and overhead movements for approximately 2 weeks to ensure the treated area remains undisturbed. Pain management. Apply a cold compress to the shoulder to alleviate pain. Prescribe a combination of acetaminophen and nonsteroidal anti-inflammatory drugs, NSAIDs, for pain relief. Key takeaways. The nature of calcium deposits: they're more like mud-sand mixtures than rigid stones. Pre-operative ultrasound evaluations are crucial for understanding calcium size, density, shape and designing the needle's approach. Aim the needle at the center of the calcium cavity during insertion. Avoid relocating or adjusting the needle post-insertion. Gentle plunger pressure ensures the calcium capsule remains intact during the initial steps. A subacromial bursal injection of steroids can prevent post-procedure bursitis. Post-treatment, advise patients to limit heavy lifting and overhead movements for 2 weeks. Cold compresses and analgesics, including acetaminophen and NSAIDs, can help manage post-procedure pain. Thank you for joining this session. By understanding and mastering the barbotage procedure, we can offer our patients an effective, minimally invasive solution to calcific tendinosis. Stay tuned for more insights in this series. Join our masterclass membership today and unlock a treasure trove of knowledge. Benefit from twice-weekly videos, including inspiring lectures, clinical case discussions, and image interpretation insights. Elevate your skills and connect with like-minded doctors. Subscribe now for a brighter professional future.